common between zebras and NETs. This is actually the logo that was selected by the International NET Alliance, and the logo that they have is Think Zebra. If you don't think about it, you won't diagnose it or detect it. And here's the blurb that they put on their website, sort of highlighting the significant heterogeneity of NET patients. We all see a little bit different clinical profile depending on where our practices are, and we all look at it a little differently, and certainly there's a lot of diagnosis, pathology, very heterogeneity. That makes this a very challenging disease to look after. There are many beginnings that led me to start on this journey setting up radionuclide therapy, and I could highlight 3 of them. The first one is a patient. Stephen Gallinger referred his patient to me. I don't know whether he liked me or not, but this patient is a physicist, and he had metastatic neuroendocrine tumor. He came to my clinic always armed with the latest research that he has done. He sat there, talked to me. I freely admit I've never heard of this before. Let me go and read about it. And then he come back and we had another conversation. I never treated him, but I understood the plight of these patients and the challenges that they face. And certainly patient advocacy has been an important part of this journey. The second one was our strategic planning for our department. We talked about various things in which we should be thinking about, and personalized targeted therapy is a key one. And we asked ourselves, why are radiation oncologists not really involved in the use of radionuclide therapy? Indeed, why? And that's one of the questions that led me to spend some time on this. And finally, as the co-chair of the CCO GI guidelines group, I was given the opportunity to be involved in the expert panel for neuroendocrine tumors. I guess I'm as expert as anyone at the time, given that this is a disease that generally do not involve a lot of external beam radiotherapy input. And we were able to look at the literature and look at it objectively and contribute to where we should be going. So over the next 45 minutes, we hope to touch upon what the zebra looks like. And Shereen is going to talk about this. And then we'll talk about what the evidence is in terms of peptide radionuclide therapy, specifically in lutetium delivery, and what our solution is, and a few thoughts at the end. And Stephen is going to talk about perhaps one of the most interesting piece of this journey, understanding the dose delivery to these patients, which in the traditional model of delivering nuclide therapy tend to focus on what radioactivity is in the tube as opposed to what dose the patient is getting. And this is an exciting piece that we want to learn quite a bit more in time. So, Shereen?
Thanks, Rebecca. So over the next 15 minutes or so, I'm just going to give you a bit of a perspective on really why this needs to be set up and really how Canada and North America has been behind really in many respects. And part of that has been a major obstacle is many misconceptions amongst the medical community that these are cancer-like, and that's why in medical school they taught us carcinoid, and you'll see in a minute that this is totally wrong. The other is that everybody remembers carcinoid is flushing, wheezing, and diarrhea, and that's also completely wrong. And the reason for that is that you're going to see that there are many diagnoses in this disease, which I think are really very important for you to really appreciate, whether you're from a medical or radiation side, and it obviously very much influences the different types of therapies. And I have to do this so that you can understand where the PRRT is really going to come into place. So in order to do this, I'm afraid I'm going to have to bring you back to embryology. And just if you recall the ectoderm, mesoderm, and endoderm classification, everybody recognizes that sarcomas are derived from mesoderms, CNS tumors arise from ectoderm, and really what we're talking about here are diseases that are mostly arising from the endoderm. And just want to remind you, these are epithelial cancers, so they're cytokeratin positive. But what distinguishes them from the garden variety adenocarcinoma that you treat every single day is that they also have neuronal elements. So it's an epithelial cancer with cytokeratin and neuronal positivity. And that's fundamentally very, very critical for everybody to really appreciate, because sometimes the diagnoses are limited to only a small biopsy and aspirate, which can be very difficult to classify, and ideally you want tissue, or at the very least a core biopsy. I also want to remind you that there are some instances where you start off with an adenocarcinoma that undergoes later transdifferentiation, as in the prostate or breast, where the adenocarcinoma starts to acquire neuroendocrine differentiation. That's a very different beast. I won't go into some of the more sort of unusual neural crest-derived neuroendocrine tumors. These include medullary thyroid cancer, or the predominantly neuronal type of cancers, including paragangliomas, a disease that's often not really very well appreciated, as well as pheochromocytomas. So the neuroendocrine cells really are dispersed all the way through. So it's not the small bowel anymore. We're talking about every component of the body: respiratory tract, GI tract, CNS, as well as GU tract, can potentially, in the same way as you can get an adenocarcinoma, you can also get a neuroendocrine type of tumor. And these are characterized, as I said, of the capacity to also be able to make hormones, which can create and potentially be associated with a clinical syndrome manifesting itself with excess of hormone. Now, the second thing is, everybody says, well, these are extremely rare. And really what's happened from Sears data, and this is now several years ago, you can see is that actually the incidence, these are all neuroendocrine tumors, are actually rising in the lung as well as in the GI system. These are the diagnosed cases. We're not even talking about the ones that are not diagnosed or missed. And you can see within the GI tract, it can be anywhere from the duodenum all the way down into not just the small bowel, but the rectum and the appendix. And that can be really quite problematic, and you'll see in a minute how that's very important. Just to give you a perspective of Ontario figures, we see roughly 3,000 cases per year, new cases of neuroendocrine tumors, and Princess Margaret will get at least 10% of those. Problem is that most of them are like what Rebecca showed you. They come in when it's too late, stage 4, widely metastatic disease, missed for many years, and the patients are really very upset. And that's why there's very strong advocacy in the public to do something about it. So the second problem that we have is that it's very difficult to actually diagnose the potential for malignancy and progression on the basis of biopsy alone. So sometimes we rely on cytology just to tell us that it's neuroendocrine. We rely heavily also on proliferation markers, and some of you may or may not be familiar with the Ki67 or MIB1 labeling index, which really is an index that marks DNA replication. It's immunohistochemical, it's quantifiable, and actually you'll see in a minute of how that can be used to grade the tumor, but also we rely heavily on evidence of tissue invasion into blood vessels and surrounding structures. So the WHO actually likes to classify these into grade 1, 2, and 3. So this end would be sort of the small cell cancers, if you will, of the lung, or large cell endocrine carcinomas. And it's based on the mitotic activity as well as the Ki67. And these are really the 3 categories. A lot of times, obviously, there's a bit of an overlap, and sometimes patients fall into that gray area where we really don't know how to best initiate therapy. But we're really trying to look at this more carefully on the basis, not just on tissue and the classical markers, but also on the basis of genetic events, and I'll show you some of this in a second. But just to, even with a very crude WHO grading, you can see that survival looks very much like this. If you remember Steve Jobs, he actually started as a WHO 2. He was told to go to Mexico and do all sorts of unusual things, and he shifted over to a grade 3, and that's when hell broke loose, and actually he succumbed to the disease afterwards. So it's not unusual for patients to actually move from one grade to the next as the disease progresses. This is just one of the early studies back in 2008 that really started to compare within the same organ pancreatic adenocarcinoma and neuroendocrine carcinoma, and as you can see, the genes are completely different and not overlapping. For example, P53 and RAS, which are very heavily involved in pancreatic, are unseen and not seen at all in neuroendocrine, and vice versa. If anything, what you start to see are more signatures of events that are associated with brain tumors, with cancers, DAX and ATRX. And these can be detected even by immunohistochemistry, where you can actually see the loss, and in pancreatic and glioblastoma, the similarity is really quite striking. Small bowel has been very difficult to identify because all of the genes that we know about in the GI tract have really evaded detection in small bowel neuroendocrine tumors, and it's only relatively recently that with deep sequencing it became obvious that the cyclin-dependent kinase inhibitor P27 in the nucleus, which basically stops cyclins from activating cell cycle progression. This is a tumor suppressor. It is lost or downregulated in these small bowels. And interestingly, you can see multiple small bowel tumors, multiple primaries in the same individual, and unless these are identified early on, many of these tend to progress to the point where they evade detection and they metastasize early, as Rebecca showed you earlier. Princess Margaret is now a member of a very large international neuroendocrine tumor consortium, and its effort actually is to do the entire genetic landscape of neuroendocrine tumors, and this is just some early data that I want to show you. The most important thing that you want to see from this slide is, number one, is that colorectal, small bowel, and pancreas are completely different. But if you look very closely, you also start to see that the genetic events, which was completely unexpected, are also present in the normal tissue. In other words, unlike the classical thinking where we typically identify somatic events, it appears that with neuroendocrine disease that many genes are present in the germline. And this is a very important feature, and it actually is becoming more of an issue in many other types of cancers, but heavily represented in neuroendocrine tumors, and many of these genes are involved in chromatin remodeling. So it's not so much the DNA, but rather how the DNA is packaged that seems to be affected, and perhaps this is a signal that's telling us that these may indeed be associated with exogenous stimuli, that these are genetic events that are triggered by some environmental infection or toxin or something of that nature. So with this in mind, then I won't go through all of the details, but just to tell you that surgery is typically our first attempt. We try to cure these patients, but often we fail because of late detection. We often try to just simply debulk them. At the time of surgery, many of our hepatobiliary surgeons will perform radiofrequency ablation with assistance from interventional radiology at the time of surgery. And afterwards, we bring them in, we take them up to 17th floor, and we perform embolization. Bland embolization typically to try and capture different regions of the liver as long as the disease is localized to one region of the liver. In situations where this is not possible, obviously we go into medical therapies, and they're listed here, including you'll see biotherapies of somatostatin analogs, interferon, which upregulates the somatostatin receptor. mTOR inhibitors have been approved primarily for pancreatic neuroendocrine tumors with very good response rates in terms of progression-free survival effects, but typically it's more for lower grade disease and typically pancreatic and not small bowel. People in Europe have been experimenting with a variety of VEGF inhibitors, although sunitinib has also been approved for pancreatic neuroendocrine tumors. Again, is for lower grade disease. And of course, this gets us into the area of irradiation, which is very important. This is just to show you really the schema. But one of the things that I think is very important for me to emphasize here is the following. Most of you, when you deal with receptors and the drugs that work on them, recognize them as tyrosine kinases. Most of these receptors get degraded, and that's how they get downregulated, and that's how these therapies stop working. The drugs that we're talking about here, actually, in somatostatin, is part of a G protein coupled system, which does not get degraded. It undergoes recycling. And this is very crucial in trying to understand what Steve is going to talk to you about. Why? Because here we provide an analog that binds the receptor, it gets internalized, and the radiation is really coming in as a chaperone inside the cell, and it keeps recycling over and over again and does not undergo degradation. And that's a fundamental difference between G protein coupled systems and tyrosine kinases. So just to summarize then, we try to, most importantly, identify the disease early. We try to identify the grade as best as we can, and this typically will require very good pathology and classification on the basis of lots of tissue. And most of the grade 1 patients will undergo somatostatin therapy, and in Europe, typically they use a lot of interferon and Avastin early. We don't. We tend to combine somatostatin with everolimus or sunitinib. As they progress, in addition to what I already mentioned to you, there's a lot of interest now in capecitabine and temozolomide therapies that typically are reserved for glioblastomas in the intermediate grade. And of course, the extreme case are the small cells where cis etoposide is still the main type of therapy. Most of these patients then tend to progress where we have to start looking at salvage therapy. What we want now is to be able to look at targeted therapy, and this is really where Rebecca is going to take you next to really appreciate that while initially we're going to be looking at this potentially as salvage therapy, there is the potential this is actually going to change the entire paradigm depending on our ability to be able to intervene and acquire data early on. So Rebecca, I'm on time, and you're on next.
So what is the evidence? Shereen has already explained how somatostatin analogs work. Somatostatin receptors are widely distributed throughout the body, and especially in low-grade tumors, these are present at high frequencies, and these are the ones patients that will potentially benefit from PRRT. The ability to detect patients with these somatostatin receptors and deliver a treatment that targeted is the perfect example for personalized targeted radiotherapy. And it's a model that we hope to be able to develop for other types of cancers as a model. PRRT, in terms of its timeline and development and history, is really quite young. Somatostatin was first described in 1969, and it's only about 30 years ago when the somatostatin analog or octreotide was first introduced into medical therapy. And it's only in the last 15 years or so when lutetium therapy has entered into practice and evidence has been building to support its use. This is just a table to summarize the two key agents that we're particularly interested that have emerged as to potentially most helpful in moving this field forward. Gallium-68 is a beta positron emitter that allows us to generate three-dimensional PET images that allows us to quantify doses to normal tissues, to targets, tumor targets that is being increasingly used in clinical practice, despite its very short half-life that prevents challenges to make it available on a global basis. Lutetium-177 is an agent that has a very short particle range, allowing us to deliver radiotherapy whilst limiting the toxicity to the patient, and has a half-life of almost 7 days that allows it to be transported across the globe as is done frequently to deliver therapy in certain jurisdictions. The literature was looked at through a systematic review approach, and Dr. Golinchuk has published this data in preparations for the CCO guideline using a comprehensive search. And basically, there's two studies that's generated from the Netherlands that provides us the largest body of data and the most long-term follow-up that supports its efficacy. Here's the two studies that has been published, and Dr. Kugelbaum is the lead author in both of them. And you can see that the overall survival is about 46 months. And when contrasted with historical data of the equivalent population, it probably adds about 20 months or so in terms of survival. Randomized trials is non-existent or only early data is being accumulated. It's very difficult to generate randomized trial in this type of disease where it's rare and a very long life expectancies despite metastatic disease representing one of the key challenges. Here's just an overall summary of the various types of peptide radionuclide therapy, and the lutetium and yttrium is down here, indicating a tight confidence interval and a more favorable response rate compared with other agents, hence being suggested after a lot of deliberations as the agent to move forward in this field. Despite its relative cumbersomeness in terms of delivery, is actually quite well tolerated, and it's quite well suited for this population that could live with metastatic disease but want the disease controlled without a huge amount of toxicities. The main side effect during the delivery within 24 hours is nausea and vomiting. A lot of times this is attributable to the amino acid that is needed to protect the kidneys, and with the appropriate choice of amino acids, this can be significantly reduced, and also with current antiemetic regimens. So a lot of areas actually deliver this as an outpatient, although due to radioprotection, some countries still insist in it being an inpatient delivery. In addition, there are some other side effects: abdominal discomfort, rare hormonal crisis. There could be hematological alopecia, and rare liver toxicities, and very rare deaths as a result of the treatment. In the long term, the kidney is a rate-limiting step, and a lot of the individualized dosimetry aims to address that. There's also the bone marrow, but in general terms, if the dose that the kidneys can accept, usually the bone marrow is not a rate-limiting step, although that will be the second organ of interest.
Rebecca, is this given IV?
Intravenously, yeah. So we'll updated the literature, and without taking you into each of the studies, just want to highlight that there are additional phase 2 studies since 2010. They are small, predominantly done in Europe, and there's some data from India. The focus have moved away from demonstrating to ourselves that we can deliver this and it is safe, but combining it with additional agents to try and improve the efficacy of this treatment. These are two studies that uses a non-randomized comparative design. The Switzerland study is obviously dominating with a much larger population of patients. And as you can see, this added lutetium to dotatate yttrium, and was able to demonstrate a statistically significant benefit in terms of overall survival, again lending support to the fact that lutetium is an effective agent in this patient population. In terms of ongoing trials, the pattern is very similar. There are a few phase 2 trials, as is what we have proposed as well, especially in jurisdictions where you actually have not the agent to use with to build experience and contribute to the literature, but the focus is on adding it to other agents to improve outcomes. There's a single phase 3 trial that is performed globally, but it involves lutetium, but the question is really on octreotide. I think it's the company's attempt to get the drug licensable in terms of its design. It's completed accrual earlier this year, and I guess the results will be available over the next year or two. It's also interesting to note that there's also studies looking at lutetium therapy in other cancers, and finding that it can be effective in ovarian, prostate, colorectal, small cell lung cancer, and renal cells, as examples. This is what we're trying to look at, trying to achieve. This is just an example of patients undergoing cycles of therapy and using SPECT scans to document the uptake of the tumor as well as the normal structures. And here's the liver metastases. And even by the end of the treatment cycles, you're seeing reduced uptake and responses. Gallium is the other investigational agent that is in the study that we're proposing, and the idea is that it has improved diagnostic accuracy to identify patients who have somatostatin receptors. There's a large body of literature to support the diagnostic properties and its safety. And this is the type of pictures that you could see. And in this picture, if you look at the CT scan, there's actually not a lot abnormal with the anatomy and the structural anatomy, but obviously functionally there's significant tumor involvement. Accuracy is really very high, and despite the challenges in this short half-life, there is increasing availability globally to allow it to be studied and used. So Cancer Care Ontario really is motivated by being able to provide these patients with radionuclide therapy without using special access, which is currently what is being used to deliver this treatment, and generate data that would inform and provide a stable source of treatment without sending patients abroad to have this treatment. The guideline that was developed listed these statements, and a strong recommendation is to put this therapy of make this available through a CTA and generate data that would allow us to be licensed with that goal in mind. And it's consistent with the guidelines that are available through PNETS and other collaborative groups. This is the history of where we have been. The expert panel was first convened in 2010, and with the publication of its report, as well as the systematic reviews, a consortium call for institutions who are interested to support the delivery of this treatment was made, and 4 centers made proposals, and these 4 centers now form a consortium working together to make this happen. Princess Margaret, Odette, London, and Hamilton. So we've been working furiously for the last 2-3 years. The protocol is 99.9% ready. There's been funding identified CCO to make this happen, and we're expecting to launch hopefully end of this year, middle of next year. What other activities are happening in Canada? For many years, special access was to this agent was the only route to getting it in Canada, and it's delivered in London. But now, with the consortium, we're hoping to be able to support all of Ontario. In fact, there is a discussion with British Columbia to collaborate with us. There's a study by Dr. McEwen in Alberta, and also a collaborator in John Matthew Bullegrad has also got a program going on in Quebec as well. So the design of our trial is based on all of these factors. We want to be able to provide access. So the study had to be pragmatic and be applicable to the majority of patients who might need access. It has to be feasible within our practice environment. We wanted to contribute to the literature and ultimately to generate data that would allow us to submit NDS to allow it to be licensed for long-term use for Canadians. We landed on a phase 2 single-arm study, and the design is meant to include best practices that is supported by the literature. We want to use gallium-68 to identify patients. We want to build an individualized dosimetry. We're incorporating patient-reported outcomes, and we also want to incorporate and will incorporate an early gallium scan as a tool to predict long-term responses. These treatments take about 6 to 12 weeks in between cycles, so from beginning to end is almost 3/4 of a year. And if we can have a tool that predict that they will respond or not, and switch therapy early on could be very useful, and that's the rationale behind it. This is the overall schema of our study design. We want to include patients who have progressive neuroendocrine tumor, well differentiated. We use a Ki-67 of less than 30% as our marker. When patients are, we have built in this piece that is a tumor board evaluation that we feel is quite critical in moving this forward within our practice environment. A provincial tumor board for NETs has already been ongoing. Shereen has been single-handedly making it happen every week. It allows all the experts within Ontario to look at cases and come up with a consensus. And we will be utilizing this approach heavily to arrive consensus in terms of interpretation of the clinical scenario, the imaging, pathology, etc., to decide that these patients are suitable for trial. Once it has been vetted, patients after consent will go into the diagnostic phase of the study, which include a gallium PET scan. If they are positive, then they go into the therapeutic phase, which is receiving the lutetium therapy, 4 cycles every 6 to 12 weeks, depending on recovery of side effects and hematological parameters. If they're negative, then they go into standard therapy, which could be includes chemotherapy. The outcomes we'll talk a little more in a moment. And the sample size that we're targeting is 150 patients that are evaluable receiving lutetium therapy. And we estimate that we have to accrue about 195 patients in order to get this number. Here are the outcomes that I'm particularly interested in. The primary outcome of the study is progression-free survival as judged by RECIST criteria at 12 months. These secondary endpoints are relatively standard in this type of therapeutic trial: response rate, adverse effects, and overall survival and quality of life. We also build in a number of tertiary endpoints that would help us move forward, complementing these clinical outcomes, evaluating the proportion of patients that will be somatostatin receptor positive as detected by the gallium scan, which is an investigational agent, and the value of it predicting the early second PET scan that is currently scheduled to be prior to the second cycle to predicting subsequent response. The response rate using RECIST has generally been sort of criticized for being very insensitive to responses, especially functional responses for these patients. And there's a modified Choi criteria that takes the imaging characteristics into consideration, and we'll be looking at that in contrast to our the way that RECIST defines it, as well as feasibility and technical aspects of centralizing imaging, looking at them through a multi-center setup and potentially understanding the radiomics piece of it. Individualized dosimetry is the critical piece of this study. And basically, the concept is that we want to understand how much radiation have been delivered to the critical structure, namely the kidney, and a bit to the bone marrow, which is represented by the spine. And we want to be able to measure, quantify the dose under the curve. As the lutetium is injected, it gets cleared from the kidneys very quickly, and we want to plot this curve to be able to understand what dose has been delivered, and therefore decide what the next dose should be. It could be adjusted down if the patients are not clearing their lutetium because of renal dysfunction, or it could be adjusted up if it is cleared very quickly. But we set some parameters as to the range of adjustment we would allow ourselves, and this kind of depicts what the mechanics would look like when we get the images to identify a region of interest to generate these curves for us. In order to generate these curves, we require SPECT and PECT, planar and SPECT scans. And the way that we have scheduled it is after the patients have received their treatment, lutetium, the amino acids to protect the kidneys, they get the scans at 4 hours, 24, and 72 hours. And that allows us to build this curve to generate the dose that is required. So Stephen is going to tell you a lot more about the details of individualized dosimetry, and I'll hand over to Stephen.
Thanks. So almost 2 decades ago, I finished my PhD on the internal dosimetry of beta emitters, and the conclusion of my PhD was that the physics work was, there's lots of stuff you could do in physics, but we didn't have enough information clinically to get to move the field forward at the time. So I got into the external beam radiotherapy business, and then about 18 months ago, Rebecca showed up at my door and said, "Oh, we have this interesting trial." So I've gone full circle in about 17 years. So all the grad students out there, the stuff you learn in grad school actually might come back to haunt you one day. So it's a good investment. So as Rebecca says, the critical organ at risk here is the absorbed dose to the kidney. So I'm going to go tell you briefly how we propose to calculate those doses using a very simple dose system. Now, all the radiation oncologists and radiation physicists here are used to calculating dose. In nuclear medicine, for internal dosimetry, we do it quite differently. But the basis of it is quite simple, and that's the points at the bottom, that the absorbed dose in any volume of interest, say in this kidney A here in this case, is due to the radioactivity in that kidney, and it's due to the radioactivity anywhere else in the patient. So this lesion up at B, depending on the radiopharmaceutical, may contribute dose in this volume down here. So as a physicist, we like to switch that into shorter notation with an equation. And this is this slide and the next one are just the fundamentals of internal dosimetry. So the dose to any target A, and we always think in internal dosimetry of sources, so volumes that contain the radiopharmaceutical of interest, and targets. So the dose to any target is the dose from the target to itself, say from another volume B where there's a high concentration of activity, and a dose from volume C to A. And in fact, we could continue this on as long as we want, and we could even use the entire rest of the patient with a very low level of activity as another source. So then we get into the nitty-gritty of the calculation. Absorbed dose is defined as the energy deposited per unit mass. And there's three elements that contribute to that. So all we have to do in this project is figure out what are these three, figure out how to measure these three things and multiply them together. So we have to know the number of nuclear decays in the source. And Rebecca already mentioned the quantitative SPECT imaging. That's how we're going to do that. We have to know the average energy of those decays. Now, lutetium-177 is a great isotope because it has a therapeutic component, that's the beta emitter, and it has an imaging component. So we have to figure out how we're going to deal with those, how we get an average energy there. And the last part is figuring out the average energy that stays in the target. And that depends on the properties of the lutetium, the properties of the radio emissions from lutetium-177. So going back to that equation, we can write it a little more sophisticated way with the summation sign saying that the dose to any target we want, whether it's the lesion, a particular lesion itself, or left kidney or right kidney, or bone marrow, the dose to that target is a summation of all those elements. And this is just a product I had written in text on the page before. If you don't like the big sigma sign, if you're not so keen on mathematics, think of this big sigma sign as being replaced by the orange arrows in this cartoon. So for example, if we have lutetium-177 in this source, this little orange circle says that's going to give a dose to itself. The radionuclide, the radio emissions in this source 1 will give a dose there, but they could give a dose to a second target or a third target, which might in fact be organs at risk or not necessarily therapeutic targets. And then if there's a nearby source, maybe there's some crosstalk between the two these two volumes of interest with radioactivity to give dose. So let's break this apart piece by piece and figure out what we have to measure. So the first term is the accumulated activity, which when I started in the radionuclide business, I thought, boy, that sounds really complicated. And then after about 3 years, being a bit of a slow learner, I realized that's just the number of nuclear decays. So how much activity you have and how long does it take to decay? And how does it wash out biologically? We determine the mean energy, or actually get this from tables as I'll show, that's that delta term. And then we have to figure out the mass of the target. So if kidney is a target organ in this, where we want to calculate dose, we have to have some estimation for that. Or if it's a lesion itself, we have to have some knowledge of the density and the dimensions of these targets. And the tricky part is actually this quantity called the absorbed fraction. So that's how much energy is absorbed at the source divided by the energy emitted by the target. And that depends a lot on geometry. And that's the big frustration with internal dosimetry, is that the geometry, the unique geometry of every patient can really affect the dosimetry depending on what scale, what dimensional scale you're working on. And I'll show that in the next couple of slides. So Rebecca showed this time activity curve. So we'll go through each of those three components, the three big components in that equation I just showed, and figure out how we're going to get each measurement. So the accumulated activity, as I said, is just a fancy term for the number of radionuclide decays. And we achieve that, get that measurement by doing quantitative imaging. And we're proposing to do that imaging at 6 hours after injection, 24 hours, and 72 hours. And our colleague Jean-Mathieu Beauregard in Quebec has published data, looks like this. So we have the activity, this dotted dash curve shows the activity decaying over time for two causes: the physical decay of 6.5 days and biological clearance from, in this case, the tumor site. And you can see time activity curve down at the bottom here. And mathematically speaking, if we measure the area under that curve, then we get the total number of nuclear decays. So, of course, the reason why this therapy works is that the uptake and retention in the tumor is much greater than the uptake and retention in any of these organs at risk. So quantitative SPECT imaging at 3 time points after delivery of the radiopharmaceutical. I mentioned the second term we want to deal with is the average energy, and for physicists, that's an easy one to get. This data like this is tabulated in the MERD dosimetry tables, and there are two emissions from this radioisotope. One is a beta particle, which is just an electron. And the thing with electron is they don't go very far. They have a range of only a few millimeters, especially for these low energy ones. And these are the maximum energy. So there's actually a spectrum of low energies here. So they don't travel very far. What that means is that any of the lutetium dotatate that gets to the target, the radio emissions will stay there. The beta particle radio emissions will stay there, and they won't give dose anywhere else. So that's a big advantage. And another reason why this radioisotope is an interesting one is because it also has a gamma ray, two gamma rays, in fact. Now, they don't, for every nuclear decay, we don't always get these two gamma rays out. In fact, they're pretty infrequent, but they are enough to produce an image. So this isotope, this isotope has this great advantage that there's a therapy component that's nice and contained because of the short range of the beta particles, and we're able to do imaging, and in the range of therapeutic dose, the imaging dose is not very great. So that's an advantage. So we get two features, good therapeutic radio emissions and good imaging emissions from this isotope. So I said the last term is the tricky one. This is where nuclear medicine physicists make all their money, figuring out absorbed fractions. And so we have to figure out the absorbed fraction for a particular source to a particular target. So, and I mentioned earlier, the tricky part in this business is getting the geometry right. So we're thinking of beta particles that have a range of a millimeter or two, and gamma rays that really have kind of an unlimited range. They have kind of a long free path. Most of them will get outside the patient. So if we think of those lutetium gamma rays at a source, either in the kidney or in a lesion, those gamma rays are just going to fly out everywhere. They're not going to stay in the source. They're not going to hit another target. In fact, ideally, they'll hit the front end of our SPECT scanner and contribute to an image. So the absorbed fraction for the gamma rays is just about zero. It's very small. Conversely, those beta particles, if a lutetium decays in this location, its beta particle is probably only going to go a millimeter or two. So almost all the energy emitted by the beta particles of lutetium stay in the source. So the absorbed fraction there is about equal to 1. So that's a very simplified way of looking at dosimetry, but actually the results are pretty accurate. And the problem with nuclear medicine dosimetry is that it gets more interesting as you reduce the geometric scale of the problem and say try to look at dose inside a kidney to different parts, but then these absorbed fractions are extraordinarily difficult to calculate, and they're unique for each patient. So just to sum up here, we have this dosimetry equation from the medical internal radiation dosimetry formalism. And so how do we get each elements? Well, we're going to use quantitative SPECT. We have tabulated values for the energy. Now, I mentioned the absorbed fraction we can approximate as 1 and get pretty good dose results. Or we can work with our collaborators in BC, we hope, and have kind of a pixel by pixel analysis where they apply that internal radiation dosimetry formalism to each pixel of a SPECT scan. So we get a distribution of dose in targets or a distribution of dose in lesions or organs at risk. So that's sort of where the future of radiation dosimetry has been going for 30 years. And it's never got there because this is a really difficult problem to solve. But the nice thing is we have this nice simple formalism that will get us the goals we need for the clinical trial in terms of understanding internal dosimetry. And I mentioned earlier we get that target, the mass of the whatever target we're dealing with from CT. Now, the other feature that I didn't point out here, however, if you're looking to read a chapter or two on it, actually it was in my master's thesis. Somewhere at home I have a copy of my master's thesis. I'm sure I could root out that's not holding a door open somewhere. And one of the difficulties in understanding the dosimetry is in external beam radiotherapy, we're used to giving doses in 2 gray increments over time. But this kind of dose is delivered in a very long time continuously. And the radiobiology is different. So it's very hard to make a transition. We understand very easily in radiation oncology what 23 gray in 2 gray fractions will do, but we don't know what 23 gray delivered over 8 months continuously will do. So there's also a radiobiology effect here that I haven't spoken to this morning. So Rebecca mentioned briefly dose adjustment. So I go through that formalism. The first injected dose is going to be 7.4 gigabecquerels. And I like to think of this problem of adjusting the doses that we're given a dose budget, say of 23 gray to the kidney. And we have 4 payments to make to get that dose budget down to 0. So we'll do our quantitative imaging, calculate our accumulated activity, determine kidney absorbed dose, because that's really the metric of interest. And while we're doing that, we might as well calculate doses to the lesion and the bone marrow and perhaps other organs at risk. And from that, we can make adjustment to the next dose to a maximum increase of 50% of the original value, or a little over 11 gigabecquerels of activity. So we get a new injected dose, and then we do that for the second, third, and fourth injected dose. So that's the formalism, but we have to turn that into reality. And we're using from the Techna Institute here, we're going to use the resources for quantitative imaging and personalized cancer medicine. So we're trying to get the images from each of the centers participating in the study centralized to have consistent analysis, consistent activity, accumulated activity calculations. And that's, I think, a novel feature to this, and really a fundamental one if we're going to advance the state of radionuclide therapy to get better dosimetry. We need to have consistent ways to do that rather than have little cottage industries of how to calculate dose in this difficult problem. And that's my last slide, and then there's a road that I guess Rebecca's going to speak to.
Website tells me this is in Ireland. I don't know if anybody recognizes it. Certainly throughout this journey, I think this pretty much brought you up to speed to where we've been and where we want to go. Throughout this journey, a lot of barriers have been broken down to get us this far. And it's interesting to reflect on what barriers those are and what broke down the barriers and make it move forward. And these 2 slides is just a few high-level thoughts. It's not traditionally radiation oncology disease, although I think it should be, and some of this thinking behind it will allow us to contribute the vast amount of knowledge that we have in external beam delivery in the use of radionuclide therapy. Because it's a rare disease, patients live for a very long time, evidence is not at the highest level, it's difficult to have a good consensus of what is the best way to move forward. I think in my last 25 years of experience, the rarer the disease, the more experts there are and opinions there are to reconcile, to move things forward. And to have all of the different experts in the different disciplines come together and move forward on a project did take a lot of time and effort, and luckily we are moving in the right direction. This picture comes up in my mind a lot. We all see a very different part of the problem and be able to describe it to each other and bring it together is a success that we have been able to achieve to date. Dollars is always important, and luckily CCO has made a commitment to make this available to our patients, and whilst research dollars are never enough, there's enough with CCO contribution as well as foundations and institutional support to move this forward, and we're committed to doing so. What are the enablers? Certainly the patient advocacy is a strong one. I think it's fair to say that CCO probably might not be putting as much resources behind it if it wasn't because of the patient resources, patient advocacy. And when we went to the Pre-Health Canada meeting, we also heard that they told us almost every week somebody will be calling them as to what is happening when you get radionuclide therapy. So I think that is a key component. Certainly the vice presidents and the CCO's leadership is incredible to make this forward. I think most of us are helping to make it forward, but without this vision that we want to make it happen, it will not. willingness of the various players to come to play in the sandbox and work together. And even as we move along, there are still new players that we wait to recruit to make things happen, working from the higher level to right down to the grassroots as to how to make this happen at the various hospitals. The exercise is ongoing. And finally, we need a good balance between patients as well as burning platform to make things move forward. So with that, I want to thank you for your attention. I hope you enjoyed the journey that I have described for you. And we hope that this study would get going in 2016. First patient on by the spring of 2016. The unprecedented collaboration across many, many people is just truly amazing, and it's great to be part of that. But this collaboration needs to continue for this journey to succeed. And hopefully, after 3 years of accrual and a year of follow-up, which isn't that far away, we'll have some data to be able to show that this is actually efficacious in our environment and be able to submit NDS to allow this to be available for our patients. And finally, this is a unique model for personalized targeted radiotherapy, and we hope that by learning through this exercise, we can translate this model in other diseases and use this to improve the patient's care. Thank you.